Now coming to the risk scoring system for the surgery. You have John Hopkins risk classification system, surgical risk category of revised cardiac risk index, and European Society of Anesthesia and European Society of Cardiologists have put surgery at various risk groups like high, intermediate and low groups. Individual operative procedures can vary with their perioperative risk in that category. For example, you write intra-abdominal surgery. It can be a simple appendicectomy or a Whipple's procedure. Clinical prediction tool should capture this variability in the operative risk across different procedure. And the most important thing is this clinical prediction tool should be simple and straightforward to use. Otherwise, the validity will be questioned. Now coming to cardiac surgery, what are the various risk scoring system available with cardiac surgery? You have Euroscore, STS scoring, which is a Society of Thoracic Surgeons scoring, and the Cleveland Clinic acute kidney injury risk scoring. Coming to non-cardiac surgery, you have ACS-NSQIP, which is nothing but American College of Surgeons National Surgical Quality Improvement Program scoring. And looking at certain complications, for example, you have a cardiovascular complication, you have revised cardiac risk index, and respiratory complication, you have Ariskar scoring. Apart from that, we have surgical risk scale or preoperative score to predict postoperative mortality. Now coming to John Hopkins surgery risk classification, here you have 5 classification. Category 1 is there is minimal risk to the patient independent of anesthesia, and the surgery is a minimally invasive procedure with little or no blood loss. Here the procedures are often done in an office setting with the operating rooms used only for anesthesia and monitoring. Coming to category 2, it is a minimal to moderately invasive procedure. The blood loss is not exceeding 500 ml. It has a mild risk to patient independent of anesthesia. Coming to category 3, there is moderately significant invasive procedure. The expected blood loss is between 500 to 1500 ml. It is moderate risk to patient independent of anesthesia. Now coming to category 4, it is an highly invasive procedure with the expected blood loss exceeding 1500 ml. It is major risk to the patient independent of anesthesia. Coming to category 5, it is an highly invasive procedure with the expected blood loss exceeding almost 1500 ml. It is critical risk to the patient independent of anesthesia, usually require post-operative critical ICU care stay with invasive monitoring.